I don't think I have any reminders. I would just tell you that what our program is tonight, but also just a teaser for next month. Those of you who follow international politics may know that there is a runoff election for the presidency of Brazil on the 30th of October, and coincidentally, this was not because I had any foresight on my part when I put the schedule together last February. It does turn out that Frank Cody is going to be talking to us about Bolsonaro, the presidential candidate. So he will be speaking about 2 weeks after that election, but there's likely to be some very interesting political developments in Brazil before then. So I would encourage you to make sure you're here with us next month. For now, though, we are fortunate to have with us Dr. Susan Thoms, who is going to, for the handful of you who are in here who are aging, Susan, yeah. So several, several of you may find this interesting, and share the information with your parents. But Susan is going to speak to us tonight about some of the problems with vision that again, those of you who are aging may experience. And I'm just going to turn it over to Susan to tell you about her experience, her practice. Oh, it's good to have someone young here who so we are going to go around and Andy will introduce guests at various tables. And at this table over here, we have the new member, but we introduced Denny earlier. We'll move over here to the table with Jillian and Barbara. No one there. Do we have a guest here?
My wife, Cynthia, is here today with us, and happy to have her once again.
And I don't believe I see any guests at this table, nor do I see any at that table. Yes, I'm pretty sure we have one here.
I do. I'm Rick Johnson, and my guest is my wife, Nancy.
All right. All right. So anyway, I think that takes care of our guests. I'm glad that Andy reminded us. Some of us may have, memory problems of aging. Talking about myself here. So anyway, we'll turn this over to Dr. Tom, and she will tell us all about those problems that a handful may be experiencing. Susan?
Okay. Can you hear me with the... Now can you hear me? Oh, good. Okay. Hi, everyone. I'm just going to give you about a 30-second synopsis of my background. I haven't written books, and I'm not famous for anything. I just saw patients every day for 40 years. And I trained at a time in med school and in my ophthalmology residency when women did not go to medical school and women did not go into ophthalmology. So I had a kind of a lonely trip. And I was in private practice for about 18 years, and then I joined the faculty at University of Michigan Kellogg Eye Center, and I was there for 20. And I retired from there about 6 or 7 years ago. I can't remember now. See, it's aging. So we're going to talk today about what we have to look forward to in our senior years, although a lot of these problems can occur before we are seniors. And I'm going to do this as an interactive program. I can walk around the room. I have a little model eye that we can use for demonstration. And I'll give just a little synopsis of a topic and open it up to questions. And so you will be leading the discussion. And if you talk a lot, it'll take a long time. And if you talk a little, it won't take so long. I have to tell you, though, my disclaimer, this does not establish a doctor-patient relationship. I cannot tell you anything about your eye problem, so if you raise your hand and say, my doctor told me this, I cannot comment on that. You have to speak with your doctor. We're going to talk just a little bit about anatomy of the eye so that you know what we're talking about when we talk about some of these eye problems. When you look at an eye, you have an eyeball, and you see the white of the eye. That's called the sclera. And the sclera is completely covered by a tissue called the conjunctiva. You may have heard the term conjunctivitis or pink eye. The conjunctiva is kind of a thin, filmy tissue covering the sclera. When you look at the center of the eye, you see the color part. That's the iris, blue, brown, green, hazel. But you're seeing it through the front layer of the eye, which is called the cornea. And if you think of a regular old-fashioned watch, the face of the watch would be like the iris, and the watch glass covering the face of the watch is the cornea. The space in between those two is called the anterior chamber, and it's filled with fluid. Fluid's called the aqueous humor. So that's what you see when you look at the front of the eye. You see the iris, the color part. The hole in the iris in the middle is a pupil, goes up and down with the light. And then if we cut the eyeball in half and we look at it like this, we can see that the lens of the eye sits immediately behind the pupil. And the lens will be important when we talk about a cataract. And then as you go farther back in the eye, the retina is the lining of about 2/3 of the inside of the eye. The back of the eye is completely lined by retina. And the big cavity of the eye in the middle is called the vitreous, and it's kind of a jelly-like substance. The retina is composed of millions of nerve fibers, and those nerve fibers all come together at the back of the eye and form the optic nerve. And that's what carries vision to the brain, and the brain is what really sees it. The eye focuses it and gets it there, but the brain does the seeing. Any questions on anatomy? Okay, good. Dry eyes, probably the most common thing I saw in the office through my whole career. All these older people would come in and they'd complain of their eyes itching and burning, and I rub them and I blurry when I read. And I'm thinking, oh, geez, I'm 35 years old, I get a life. I found out, what dry eyes, it is really uncomfortable. And I would say that the most common symptoms of dry eyes are my eyes are tired, they itch, they burn. I just can't, it's blurry when I read, very, very common. But interestingly, a lot of people will say, well, how can I have dry eyes when they water all the time? And that is like, well, how can that be? If they're dry, why are they tearing? And they're tearing because there are two kinds of tears. The lining of the inside of the eyelids produces the basic tears that keep our eyes moist. When the eye gets irritated, we get reflex tearing, and those tears are produced in the lacrimal gland that's up under the bone here. And so the tendency is, if your eye's irritated from being dry, the reflex tearing kicks in, and they make too many, and then they just run down your face. And then they blur your vision even more. So the key is to keep your eyes moist all day long so that the reflex tearing does not kick in. And then you block that tear cycle. Most dry eyes we treat with artificial tear preparations. You'll see on the shelf 50 of them, 50 brands. I like the ones that do not have preservatives in them or have a disappearing preservative. There are certain brands. I like the little vials that are preservative-free. You open one and it's only good for 24 hours, then you have to pitch it because it has no preservatives. There are 2 prescription eye drops for dry eyes. One is called Restasis and one is called Xydra. And those, you can't just use those when you feel like it. If your eyes feel dry, you put a drop in. Those have to be used like blood pressure medicine, where you take it every day on a regular schedule. And that helps the little glands in the eyelids to produce better quality and more tears. Blepharitis is a condition of the eyelids that makes dry eyes feel worse. It's an inflammation along the edge of the lid where the oil glands don't produce oil as well. Also, treating the blepharitis is very helpful for dry eyes. Fish oil, there is a lot of evidence that omega-3 fatty acids help blepharitis and dry eyes. I haven't taken it because I can't swallow those horse pills. They're just huge. So I don't know if they would help or not. Another more drastic measure, if those measures don't work and the discomfort persists, There's a little hole in the inner corner of your eyelid where your tears go down the drain. It's called the punctum. And you can put a little silicone plug in that punctum and block it, and then the tears stay in your eyes instead of going down the drain and into your nose. So there are many ways to treat the dry eyes. I have had dry eyes for a long time. I actually wore plugs, and I actually had my tear ducts cauterized shut, so I have no hole in my lower lid. So every little bit of tearing I have, it stays on my eye. But it's probably the most common thing I see. Anybody questions on dry eyes? No? Yes, Fred.
I always had it in the head, if your eye is dry, it's dry and it's not moist.
That's correct.
I'm learning that fatigue of the eye is a symptom of dry eye.
It can be a symptom of dry eyes. Burning, oh yeah. If you look at this picture here, this is the cornea. This is the front part of the eye here. And see those spots there on the slide that are kind of green? We put a dye in the eye called fluorescein. And if there are spots on the cornea that are eroded or extremely dry, it'll soak up the fluorescein, and when you look with the blue light, it'll look green. So all of these spots here are dry spots on the cornea, and that is extremely uncomfortable, and it blurs the vision. I actually got very dry eyes in my 50s, and I don't consider that old. But it is more common in older and more common in women than men. Not exclusively, but more common in women than men. The little glands that produce the tears just stop working. We don't know if it's hormonal or not. It has not been proven. Yeah, Jillian. Jillian asked, is dryness related to how often or rapidly you blink? And in a way it is, because blinking is what spreads the tears across the surface of the eye. And if you're staring at something, your tears are going to evaporate quicker. We blink more frequently when we talk than when we read. So if you're talking to somebody, you're probably blinking a whole lot. Yes. I don't know that that's the case. Yeah, I have not heard that. They talk more. Very good. Ken.
Yeah, this may sound like an obvious question, but a lot of people don't drink water
Ken asked about hydration and dry eyes. Yes, if you are extremely dehydrated, you are not going to produce as many tears. Hydration is important. You just don't want to overly hydrate either. Normal hydration. Yeah, but certainly if you are dehydrated, it would exacerbate it for sure. Anything else on dry eyes? Yes, Jack. Yes. Right. Jack asked about using a gel. One of these preparations, I think here, I have Gentile gel as one of the pictures I have. A gel is like a really, really thick, viscous eye drop. Some of the drops are just really thin, and they just go right down your tear duct, and they're gone. The gel lasts longer, but it will blur your vision for about 10 minutes after you put it in. I had a lot of patients that I had used gel at night, as their eyes would dry out when they're sleeping, and especially if you sleep with your eyes open a little crack, that's exposed, and that area that's exposed gets extremely dry. And the gel, or even an ointment, a lubricating eye ointment, can be used at night. Yeah, I had used gel during the day when my symptoms were really bad, but I had to know that I was blurry for a few minutes afterwards. The gels are great. Genteel gel is a great product. Not a sales, I don't represent the company. Okay, moving on. Baggy eyelids. My mother told me many years ago, as you get older, gravity pulls everything down. And I think that that is true. More than just the eyelids. What you see here in this gentleman is a big, heavy piece of skin in the upper eyelid. The actual position of the eyelid, here and here, the eyelid itself is not droopy. That's a whole different problem. That's a weak muscle in the eyelid that causes the lid to come down. These baggy pieces of skin are just like big visors in your upper lids. And that can be surgically removed. The surgery is done by ophthalmologists and plastic surgeons alike. And you can see what a nice result. It's not only a nice cosmetic result to get that skin out, but you're rid of these visors for upper eyelids, so the vision, peripheral vision can improve. You have to be real careful that everything is documented correctly, that vision is impaired. Otherwise, insurance will not pay for it. They'll say, oh, this is cosmetic. That we're not going to pay for a cosmetic surgery. But if you have documentation like measuring the field of vision, that a piece of it is blocked, then you've got a good chance the insurance company will cover it. So that is something certain. You do not want to pay the bill for that. Yes? She asked what the downsides of the surgery are. Well, any surgery carries risk. Even no matter what surgery it is, you have a risk. There's not real, well, I suppose the downside is you could take out too much skin and it's too tight and the lids won't close. You don't want to do that. And you don't want to get an infection in the stitches. So it's generally a minor risk procedure, but there is nothing risk-free, for sure. Yes, Fred.
I had that done 4 or 5 years ago. And the thing that surprised me was my ophthalmologist said there was only one doctor in Kalamazoo that was
When was that?
pardon?
How long ago was that? Okay.
So finding people in this community seems to be a bit of a problem. The other issue that I would ask is come back.
Yeah, the skin can accumulate again. The skin gets lax, it loses its rigidity.
I thought I had been told that if you go inside, it's stable.
Oh, I don't know about that. See, I can't answer that because I wasn't there. Yeah, you take a wedge of skin out, basically, and then you sew it up again. So the stitches would have been right along that line there. The stitches are kind of hid in the crease up high. That may be true that there are a lot of the people that do this are either oculoplastics specialists, so they have a subspecialty of ophthalmology. I don't know of an oculoplastics person in Kalamazoo. I know one of our U of M guys is in Ann Arbor, or in Grand Rapids, but I don't. Some general ophthalmologists do it, but not all because of the cosmetic aspect. Cosmetic patients are very hard to please sometimes. Any other questions on eyelids? All right, floaters. I bet more than half of you in this room see little specks floating if you look at a bright background. I can't even count how many little hairs, and one hair has 2 dots on it, and all kinds of funny shapes. And those are called floaters. They're very common. They are caused by little cells and debris that float around in the gel in the eye. The older you get, usually you get more. I had my first floater in medical school, and then I got more. As the older I got, the more floaters I got. They are generally harmless. They don't mean anything. They're annoying as anything if you're in a certain lighting condition. What can be significant, though, is if you suddenly see a new floater that's kind of big and you go, whoa, what is that? And it might be accompanied by little lightning flashes of light. That could indicate that the retina is tearing or is starting to detach. So those would be two symptoms: sudden onset of a flashing of light, like lightning, boom, boom, or a great big floater that you didn't see before. That would be an indication to go get seen really quickly. Somebody called my office at 9 in the morning with that symptom. We saw them that day. There was no question about it. No matter how booked you were, they were seen. Now, not maybe more than 10% of them had a detached retina, but nonetheless, you want to find that one. Any other questions on floaters? I bet a lot of you have them, I'm sure.
Well, I have them as well, and my wife was looking up something about like a BuzzFeed, something or another like that, and she's like, "What are these floater things?" I'm like, "Wait, you don't have those?"
Yeah, I know. Everybody I know has them.
So yeah, she was just surprised that these were a thing. I'm like, "Oh yeah, no, I've been seeing these ever since." Is it caused by like physical injuries or just
No, it's just the deterioration of the cells in the gel, and little pieces of gel break off where it attaches to the retina, and it releases a little garbage in the eye. Yeah, you can't get rid of them really unless you have a surgeon suck the gel out of the eye, and you don't really want to do that unless you have a serious problem. Frank. Oh, I have them all the time. I'm watching one go right across your face right now. Oh yeah, I can always find them if I looking at the right thing. I know I can identify the shapes of them, which ones are in which eye, and sometimes if I'm reading and the page is really white, they just drive me nuts. Yes. Yes, drusen are totally different. We'll actually get to drusen later. That's in the retina. Yeah, floaters are different. Mm-hmm. Flies afterwards. Yes, those are floaters from a little bit different cause, and we're going to talk about what you just mentioned, a laser treatment after cataract surgery. It's called for an after cataract. We're going to talk about that in a couple minutes. Yes, you can get floaters after that that are very annoying. Did we kill floaters? Okay. All right, cataracts. This is the biggie. Everybody will get a cataract if they live long enough. Yeah. Usually by 65, most people have the start of a cataract. It doesn't always affect vision. Might not affect vision ever or until you're 90 or 80. We don't do anything about a cataract until it affects your lifestyle. When you can't do the things you like to do, you can't drive at night and you want to drive at night because you can't see well. Cataract surgery is only done not just because you have a cataract, but because it interferes with your life. What a cataract is a clouding in the lens in the eye. Now we remember the lens here, if we look at our eyeball, the lens sits right behind the pupil. So if you're looking at the front of the eye and you're looking into the pupil, what you're seeing in the pupil is the front surface of the lens sitting right there. And in this eye, you can see all those little cloudy white things. That's a cataract. Now that's a pretty advanced one. That person would not be seeing very well. Most of the ones we remove, we don't let them get that bad because they really start to bother us because we're so active. We do a lot of things. We're driving. We want to do stuff. And a little bit of a cataract is going to bother a lot of people. When the light comes into the eye, how we see, it enters the eye and the cornea starts focusing light beams, and then the light goes through the lens, and the lens focuses what we see to the back of the eye, and it focuses onto the retina. If all of this is nice and clear, you get a nice clear image. It focuses right to the retina. You have a cataract, the light's just going to go every which way, and then you get a blurred, obscured image like that. So if you see like that, that could be something else too, but it could be a cataract. So we decide with the doctor, yes, it's interfering my life. I can't do all the things I want to do. I want to have it out. So here's how we do it. We actually make, I was going to say, you can see you've got your own screen. We actually make a little tiny cut on the edge of the cornea, and we go into the lens of the eye, and we've opened the lens. The lens is like a grape. The grape has a peeling around it, and the inside of the grape is kind of soft. So we make an opening on the surface of the lens in the peeling that's around the lens, and we go then with this is the opening in the peeling. We go into the body of the lens, usually with an ultrasonic tip, and that ultrasonic tip fragments and emulsifies the lens inside, and it sucks it right out. So then we're left with this peeling with the hole in the top, an empty sac basically, and we can inject a lens right into that part to replace the natural lens. And that lens is called a lens implant, not a transplant. It's an implant because it's made out of a non-human material. It can be made out of PMMA plastic, it's made silicone, acrylic. I used pretty much acrylic lenses when I was doing cataracts. And then that lens goes through that tiny incision, and it's injected into that sac, and it opens up, and these little posts here lock it into position. This is a prescription lens. So if you were really, really nearsighted and you have your cataract removed, that prescription that's in your nearsighted glasses can be put in that lens that goes in your eye. And so people who wore really thick glasses all their life suddenly aren't wearing glasses or are wearing a very small prescription in their glasses. It's really quite phenomenal. There are a lot of new implants now. When I was operating, we pretty much had standard lenses. They were having some that corrected astigmatism, and those were called toric lenses. Now they have lenses that are bifocal implants. Yeah, it's just incredible. And they work fairly well. There are a few little glitches with them, but insurance will only pay for a standard lens. And the surgeons that do these, they call them premium lenses, which would be the toric lens and the bifocal implants, generally are $2,000 to $3,000 an eye. They charge extra to do those. But you can really get miraculous improvement in your vision after the cataract is removed, and the lens implant can correct whether you were nearsighted or farsighted. It's pretty phenomenal. Now, you had asked about having a laser treatment after cataract surgery. And what happens after the cataract is removed, this sac that the lens sits in, the back wall of the sac can opacify, it can get cloudy. And then it's like having the cataract all over again. You can't see very well. And there is a laser, it's called a YAG laser, Y-A-G. And the YAG laser can be aimed at that cloudy spot, and it just kind of goes poof, and you make a few shots at it and it goes away, but it leaves you with some debris floating around. Usually that debris will settle down with a little bit of time, but sometimes you are left with some floaters. But then that opens up, that makes that zone all clear again, and you have that nice sharp vision back. It's really pretty amazing. Any questions? I imagine some people here have had their cataracts removed. Yes? It's a clouding in the lens. Age. But it can also, everything. It can also be related to certain medications. If you take steroids, if you have to take prednisone for asthma or some kind of a immune disease, steroids will give you a cataract much earlier. That's one of the medications that's notorious for giving you a cataract. Diabetics tend to get cataracts at a little bit younger age, but they get a lot of stuff earlier too. Exercises for the eye, not really. I suppose if you were a child and you had a weak eye muscle, you would do some exercises to work on that eye muscle to align them. But as an adult, no. No, nothing. You don't need to exercise your eyes. Yeah, she asked about the toric lens implant, which corrects astigmatism. All astigmatism is, remember we talked the corneas. The cornea is the very front watch glass part of the eye. If you do not have any astigmatism, the cornea is like a basketball, perfectly rounded, spherical in all directions. If you have astigmatism in your cornea, it's shaped like a football. So you have two curves running perpendicular to each other. They can, when I have a moderate amount of astigmatism in my right eye, and my glasses have one prescription running one direction and a different prescription running the opposite direction to correct both of the curves. The implant also would have two different curvatures, just like the glasses. And when that's placed in the eye, it has to be rotated so that the little lines where the maximum power is align with the right place on the cornea. So you have to make all kinds of very careful markings and measurings. So that's what the toric lens does, is it will correct the astigmatism just like your glasses do. It has to be aligned just right. I did some of those. They were tricky, but really gratifying. I want one in this eye. Any other cataract questions? Yes. I have no idea. I can't, I wasn't there. I have no idea how to explain any of that.
The name of the problem was not a cataract.
I can't tell you either. I have no idea.
It was something else was the problem. I had to go back 3 times to get the pieces.
Oh, well, yeah, I have no idea what that was. Any other cataract questions? Okay, onward. This is the biggie, macular degeneration. This is the scary one for most of us. We're seeing a lot more macular degeneration because it's age-related and people are living longer. And they want to live nice, healthy lifestyles. They want to drive, they want to read, they want to do everything. And if the center of the retina, called the macula, deteriorates, you lose your central vision. If I look at Cynthia and I put my hand in front of her face, she's kind of blocked out. I can see Fred and I can see Gary in my peripheral vision, but they're not clear. Your clearest vision is the very central point in your retina. That's called the macula. It's what faces straight ahead. All the rest of the retina, the peripheral part of the retina, sees, but it doesn't see 20/20. It doesn't have that nice clear vision that you like. So this is what normal you would see the kids. And if you have macular degeneration, the central's kind of blurred out, but you can tell that there's a fence there, and you fence there and a little bit of the ball, but it's not sharp. And that's what happens in macular degeneration. This is a picture of the retina. And if we look inside the eye, I don't know if you can all see that, what you're looking at is the way in the back, the lining in the back part of the eye. We can pass this around later if you want. And the very center part that faces straight ahead, right there, is called the macula. And the center of the macula is called the fovea. That's where your absolute perfect vision is. If you get pigment disruption in the macula, that would be called dry macular degeneration. and that's where drusen are. Drusen occur in the macula, and they're like white spots. And drusen is an early sign or the beginnings of dry macular degeneration. The other type of macular degeneration is wet macular degeneration. And this occurs in about 20% of people who have dry. They'll progress to wet. And abnormal blood vessels will begin to grow under the retina, and they bleed. And this bleeding, in this slide you can see, this is just a little disruption in the pigment. It's a little spotty looking. Here you've got a big hemorrhage right in the macula, and that just really wipes out your whole central vision. And that's what you don't want to have. And it's age-related, and there's a genetic component too. My father's side, everybody had wet macular degeneration. And I figure if I live long enough, I will probably have it. I just hope they know what to do about it by then. Maybe it'll still be a while. So when we are following patients with dry, we want to know if they convert to wet, and we want to know right when it happens, because the sooner you get it, the better you can do something. And we often send patients home with something called an Amsler grid, and it's like a piece of graph paper with a dot on it. You stare at the central dot, and if everything that surrounds that dot looks nice and square, you're still probably dry. If all of a sudden one day you see bumps like that, a distortion, that could mean that there's blood under the retina causing the distortion. That would be an urgent thing to get in to see the doctor. If a patient called in the morning and said, I woke up today and my Amsler grid changed, they come in. There was no ifs, ands, or buts about it. Generally, when someone has dry macular degeneration, we say eat a healthy diet, eat lots of leafy green vegetables, don't smoke. Smoking is really bad for macular degeneration, and wear UV sun protection. Sunglasses, or my glasses have UV block. Most clear glasses can have a UV blocker in the lens. Yes? Yeah, each eye separately. Yes, absolutely. Each eye should be checked separately. Jack? Is it? You bet. You can actually look at the corner of a door and achieve the same thing. What you want to look at is straight lines, and if you see a blip in your straight line, that's a signal. That's not good. So no smoking, UV block in your glasses, all good idea. Dry macular degeneration, if you have it to a certain level, which we would call moderate dry macular degeneration, it's recommended that you take the ARIDS formula vitamins. This is from a study done about 20 years ago. My dad was actually in the study a long time ago. And they treated thousands of patients. This was a national study with vitamins, with certain vitamins and not. And they found that the ARIDS vitamins formula reduced the progression to wet macular degeneration by about 25%. Not much, not a cure by any means, but maybe any little bit counts. The first formula that came out had vitamin A in it, and it was found that vitamin A helped people get lung cancer. It promoted, if you were a smoker, you didn't want to take vitamin A because it could help make you get lung cancer. So they substituted the vitamin A, they substituted lutein and zeaxanthin, which are two carotenoid pigments. Lutein is in egg yolks, and lutein and zeaxanthin are in the macula, in the cells of the macula. Taking extra, I guess, maybe helps a little bit. And then the other vitamins, vitamin E, zinc, and copper, all part of the ARIDS 2 formula, and that's what's still recommended after like 20 years, taking it for dry macular degeneration. The wet kind, there are have been some new treatments evolving for wet macular degeneration. Because it involves growth of abnormal blood vessels, there is a factor called VEGF. It's VEGF stands for vascular endothelial growth factor. So it's some factor that promotes the growth of abnormal blood vessels. And we have a substance that are anti-VEGF substances that we can inject in the eye, and it slows the growth or stops the growth of these blood vessels temporarily. So if you have blood vessels and bleeding in the macula, you can give an injection. Let's see, you can give an injection, and yes, the injection goes right into the eyeball. I did it by a diagram and not by a real photo because I thought somebody might freak out. And the substance that goes in, there are three different ones. Avastin, Lucentis, and Eylea are the three different companies that produce an anti-VEGF drug. It's injected into the vitreous, right into the gel. It's absorbed underneath the retina, and it stops the bleeding. For about 6 or 7 cycles, the injection might need to be repeated about every 6 to 8 weeks. Then sometimes the time frame can go a little bit longer, and it may be every 3 months or every 6 months, but it's something that has to be followed meticulously every few weeks to start, and then every few months, and then get re-injected if you need it. That's a very good question. How do you overcome the horror of sticking a needle in someone's eye? And I have to admit, when I was a medical student, I did an eye rotation at a clinic, and I saw somebody giving an injection under the eye, not even into the eye, but under the eye, and I thought I was going to faint. But then you sort of get used to it, and you realize that it really does produce results, and you get used to using needles around the eye. And the fact is, you can hold the patient's hand and you can really talk them through it if you're very gentle. Do I work under a microscope for cataract surgery? Yes. When we do a cataract, the patient is lying down on a table and we're seated at the side of the head. There's a big operating microscope over the eye. We're looking through the oculars, and we're working down here with little tiny instruments at magnification. So everything, you move a millimeter and it looks like a baseball bat's moving around. You cannot have a tremor. No caffeine. No, I still don't drink caffeine. Fred. We don't use AREDS 1. We don't use AREDS 1 at all. No. Okay, the AREDS 2 formula, Fred asked about the AREDS 2 vitamins. They are given for people with dry macular degeneration in hoping of slowing the progression to wet. But you don't take it unless you have moderate macular degeneration, like white spots in your macula, drusen. Then you might be prescribed the AREDS 2 formula. Some people will still give it even if you are already in wet macular degeneration. I'm not convinced it does that much good, but certainly give it for dry if it's at a certain level that could progress. Way back there, I can't see you. Okay. You start getting, I can't quite hear you. Oh, tremors. Right. Mm-hmm. Yeah, that's what patients tell me too, that it's really not as bad as it sounds. Once you get over the initial thought of sticking a needle in your eye, that it's not as bad. They say, oh, that wasn't so bad. And then if the results are good, then then it's really effective. Yes?
So the injections inhibit undesirable blood vessels from developing.
Yes.
30 years ago, foreign.
Mm-hmm.
And they had to put a stop. We use laser treatment
Yeah.
to kill cells, you know. Would this, nowadays, would this have been an alternative?
Probably. That was pre-anti-VEGF drugs. We used to treat macular degeneration wet with laser before we had the anti-VEGF drugs. That you laser the abnormal blood vessel and you destroy it, but you're also destroying retina all around it at the same time. So it left a significant blank spot. But the anti-VEGF drugs don't destroy retina, they just shrink the blood vessels. So there's a huge advantage, but is that Ross back there? As he said, you have to keep repeating it because it slows them down, but then they come back. So you have to keep doing it. You have to keep at it. But yes, my guess is, I wasn't there, but my guess is you would have been treated with a VEGF drug. Yeah, probably. It might have been there. There are various companies. The actual ARIDS formula is made by Bausch and Lomb. There are some other companies that I think are kind of knockoffs, and if my guess is he probably owned interest in a company that he was promoting the vitamin, but it probably wasn't the actual ARIDS formula. Yes, it's amazing how they promote what they own. Yes. Never heard of it. News to me. Yeah, that's something I'm not familiar with at all. Hasn't been in the literature I'm reading. Oh, he has the shots, okay. Frank. Yes. Frank asked about how do you diagnose the difference between dry and wet. First of all, it's a very clinical diagnosis. You look in and you can see spots and it looks dry. There could be a little suspicion of wet and you're missing it. And we have a scan that we can make of the retina called an ocular coherence tomography. It's a scan that scans the thickness of the retina. And it will pick up a little tiny blood vessel in that scan that you might not be able to see with your eyes. Before we had that, we did an angiogram where you get a dye in the arm and it circulates to the retina. You take a lot of pictures. You'd pick it up that way. But initially, most of them you can see. You can look at it and you can see. Anybody who gets the injections, I bet Ross, before you get the injection, you get the scan, and then they inject you after the scan. They verify that there's activity. Pictures, yeah, it's a photographic scan. Yeah, that's pretty standard. Yep. Yeah, there are several ways to tell. And the technology gets better and better all the time. I think back of when I started my residency in 1975, what we did and had then and what we have now is just blows my mind. It's very exciting. All right, I got a couple more. Do you want to go on or are we tired? Okay. Glaucoma, very common eye disease. And it's really a three-part puzzle. We used to say, oh, well, your eye pressure is elevated, you have glaucoma. But that's not really totally the case because there are people with some elevation in their eye fluid pressure in the eye, but they don't have glaucoma. And there are people with normal eye pressure and they do have glaucoma. So there's more to it than that. And the three parts to that puzzle are, one of the parts is pressure. One is whether the optic nerve is damaged and whether that damage is causing loss of field of vision, loss of side vision. So there are three things we look at. You've probably all been to the ophthalmologist. You've all had your pressure measured in the eye. Sometimes it's with a poof of air, and often it is with this instrument that actually indents the surface of the eye and measures the pressure that way. So that's step one. Step two is we look at the optic nerve when we examine the eye. And this is a picture of the optic nerve. We can see that when we look in the eye. It's right in the back. That's where all the nerve fibers come together from the retina, and that's what goes back to the brain. And we can see that all those nerve fibers come together right there, and then that goes back into the brain. And this is a normal optic nerve, nice and pink and healthy. And this optic nerve has this big indentation in it. We call it cupping. And it's like looking into a bowl when you look at it in 3D. And that is a very typical glaucomatous optic nerve. And it may or may not be related to elevated pressure. But when we see that, we have to be suspicious for glaucoma. And that damage to the optic nerve will cause a defect in the field of vision. Some of you may have done a visual field test at the ophthalmologist's office. And you sit at a machine, you look into a bowl, and the technician runs the program, and you have a Jeopardy button in your hand, and when the little lights flash in your side vision, you push the button. And if it maps out an area that you did not see the light, it's called a scotoma or a blind spot. We all have a normal blind spot that's right about there, but if you have a big blind spot, like part of the upper field or part of the lower field of vision is missing, that could be an indication for glaucoma. So we look at the pressure, we look at the optic nerve, and we look at the field of vision. Even though pressure isn't the whole story, the treatment for glaucoma remains lowering the eye pressure from your baseline. So if a normal eye pressure is 20 and your pressure is 19, but you have field damage and you've got an optic nerve that looks sick, you're going to try to lower the eye pressure to 13. If your eye pressure is 26, you want to lower it to 19 or 20. So basically, you want to lower the eye pressure from your baseline pressure. Usually done with eye drops, but can also be done with laser. If you don't see well, you mean? There are a lot of studies on people, probably most of them done with macular degeneration, but studies on falls, people who fall, vision related to falling, and psychological testings, depression. Depression is very common in people with vision issues. Oh yeah, if you're 65 and you're getting macular degeneration, you can't drive anymore, I'd be pretty depressed. So yes, there are a lot of things that vision affects your whole well-being for sure. Okay, we've killed glaucoma. Last slide. Well, not quite. The last subject, diabetes. And I'm not going to go into a lot of detail. Diabetes can do horrible things to the eye as it can to the kidneys and other parts of your body. And what happens in diabetes, diabetic eye disease, this is a nice normal looking retina. This is the optic nerve. This is the macula right here. This is a left eye. And in diabetes, all the little tiny blood vessels all throughout the retina leak and bleed. And that can certainly knock your vision down, especially if the leaking and the bleeding is in the macula, which is right here. All these white spots are swollen areas. The red spots are hemorrhages. We had often, like you mentioned, laser. We used to treat that with laser routinely. We'd do an angiogram, we'd see all the leak spots, we'd zap those with a laser beam. They're now treating this with the anti-VEGF drugs as well, and injections. So those injections, drug companies that make those injectables are raking it in, because they are not cheap. So one of the things in diabetes, controlling your diabetes from the get-go. If you're told you're diabetic, do what the doctor says, because it's easier to prevent it from occurring by meticulous diabetic control than it is to treat it once it happens. Any questions on diabetes? I just sort of skimmed that one kind of lightly because we're at the end and we're all tired. Both. Type 1, if you're a juvenile diabetic and you're diabetic from age 8, you're going to probably have retinopathy in your 20s, by your 20s. Type 2, maybe not as often or severe, but certainly very possible to occur in both type 1 and type 2 diabetes. Diabetics should get their eyes examined at least yearly, and more than that if they are starting to show any retina signs at all. All right. Should you take vitamins? Everybody, you know, these companies sell you millions and millions of dollars worth of vitamins. And the fact is, for your eyes, if you eat a healthy, balanced diet, you do not need to take a vitamin. If you have moderate macular degeneration, yes, you should take the AREDS 2 formula. But if you don't have macular degeneration and you eat well, you eat fruits and vegetables and a nice balanced diet, vitamins are really not going to add anything. Omega-3s, there is some evidence that it helps slow macular degeneration, although there's not really solid evidence for that. And there are a lot of people that say it does help with dry eyes. But so I don't take any vitamins at all. I eat lots of healthy food, lots of green vegetables. And I just think that, for me, they're a waste of money. But a lot of people really live on these vitamins. Drug companies make a lot of money on them. Any other questions? That is the last slide. Well, carrots have vitamin A. That vitamin A is necessary for the rod cells in the retina, which function in night vision. But if you eat a normal diet, you're going to get enough vitamin A. If you don't eat any vegetables and you are totally vitamin deficient, then yeah, you might have night vision trouble. Absolutely.
Well, we all know that the whole carrot story with World War II, right? Do you know that or
No?
no? The British had discovered radar and were using that to find the German bombers that were trying to bomb the UK, but they didn't want to let the Germans know that they had discovered radar. So they had gone through the study that, you know, they were going out there with propaganda saying that, oh yeah, all these British, you know, soldiers and everybody are eating lots of carrots, so they have really good night vision. And that's how they're starting all the
Oh, love it.
So yeah, the whole thing about carrots is entirely World War II propaganda.
I never heard that. That's great. I love that.
And my mom told me that too, and I was like, I saw on the History Channel that you're wrong. Yeah, never tell your mom that she's wrong, and the TV told her that you know she was wrong.
Any other questions? If anybody wants to play with the model, they can.
I think that's all we have. And of course, Andy, if it's on the History Channel,